Hello everyone, good evening. Hope I'm audible. Okay, I think while the others join, we can get started. So I welcome you all to this masterclass on mastering the anti-cancer therapy. We have a speaker today, Dr. Pavallika. Ma'am, I welcome you. Dr. Pavallika Utukuru is a family graduate with residency in oncology. She has gained specialized expertise in oncology pharmacotherapy. She was awarded the prestigious Vasavi Union Charitable Trust Gold Medal for her outstanding academic achievements. With extensive experience as an oncology clinical pharmacist, she's played a key role in implementing standard practices, reducing medication errors, and improving patient outcomes through compassionate care for cancer patients. She has trained both national and international students, educated nursing staff, and mentored interns and professionals in oncology and clinical pharmacy. She is a former assistant professor in pharmacy practice. Dr. Pravalika has been invited as a speaker, panelist, and a judge at various conferences and has delivered insightful online lectures on oncology. Currently, she serves as the head of clinical pharmacology and clinical assistant in oncology at KIMS Hospital, Gachibowli. As a part of the medical team, she has contributed to successful stem cell transplant and CAR T cell therapy, further enhancing patient care in medical oncology, hematology, and bone marrow transplantation. Ma'am, thank you so much for joining us. I'm sure most of you would have already attended ma'am's previous lecture because she's been associated with us for a long time now. But for the newcomers, I thought we could just introduce her. Ma'am, welcome.
Yes, I'm here. We'll start the class. Give me 1 minute. I'll share it.
Sure, ma'am.
Sorry, guys, for being late, but I'll share everything. In today's class, we'll try to cover most of the things. I'll start off my class.
Yes, ma'am, we are ready.
Okay. Guys, don't mute your mics while we go. Am I audible? And my screen is visible. Please keep typing in the chat box.
Yes, ma'am.
Don't get worried about the terminology that you'll be listening here. The first thing. Okay. I'll start my class. Before we start my class, how many of you are new to my class or have new to the oncology session? Or have you ever listened to my class previously? Any oncology classes? Are you aware of the basics? How many of are new? Okay. Okay, let me know initially how many of you are new so that I'll tell you some basics. I'll not go so deep. Maybe my presentation may be containing many new things that you will not be able to catch up. I will summarize them. Okay, most of you are new. I will be thinking
Actually, few
all
of
of
them are
you are
new
new.
and few of them are from our the masterclass batch.
Okay, I will think everyone is new to my class.
Sure, ma'am.
So
We can
I will
start
teach
with a
in
little
that
bit of
way.
basics.
Yeah. So before we start, see, clinical pharmacy, in simple terms, you people no need to worry about the diagnosis part, irrespective of whatever the diagnosis is. And you have to worry on how you will have to play your important role in checking the medication charts. Okay, medication chart, does not mean it is containing only the ongoing treatment medications. Suppose a patient gets admitted to the hospital, he will be coming with C. He may be a diabetic patient, he may be a hypertensive patient, he may be having comorbid conditions, or he may not have any comorbid conditions. So, but patient will come to the hospital with some certain complaints. Maybe he's having loose stools, fever, headache, all these complaints irrespective of what are his comorbid conditions and what treatments he is already undergoing. Okay, when patients get admitted to the hospital, your primary goal of therapy or treatment would be to resolve those symptoms and identify what is the reason for the cause of those symptoms. Whether it is a viral fever or any gastroenteritis, based on the symptoms, you'll have to diagnose and you'll have to treat the patient and send him back from the hospital. That is, you are providing the treatment for the current diagnosis. That doesn't mean that you have to ignore his comorbid conditions. So you will do some activity called as medication reconciliation. Medication reconciliation on the medication chart. You cannot ignore the patient's ongoing medication. So you will have to take the brief history of patient, complete history and ongoing medications, and you will have to update all the medications in the medication chart and all the drugs to be administered from the hospital, from the nurses to the patient. If the patient is having the medications by his side, you have to mention the patient's medications are being given from the bedside. Okay, because we will have to know what are the ongoing medications completely during the hospital. Okay, that is very important to avoid drug duplication, to avoid drug interactions, and to ensure the complete treatment is being received by the patient. We are treating him for the current condition doesn't mean we are ignoring his comorbid conditions. Did you understand in brief why we have to do medication reconciliation? Yes or no? I want a very interactive class. Yes or no? You should keep replying me in chat box. Then only I'll go for next slide. Yes? Very good. No doubts? Then I'm going for next. So we will be discussing about anti-cancer drugs. What are the principles of anti-cancer therapy? What is protocol optimization, drug interactions and compatibility, drug targeted and immunotherapy. Please don't get confused in drug interactions and targeted immunotherapy because I brief them. Okay. Don't get worried by seeing the pictures and all. Prevention and management of adverse effects, supportive care medications, and we'll have some case discussions. Okay. Next one. First of all, what is tumor? It is a mass of tissue formed as a result of abnormal, excessive, uncoordinated, autonomous, purposeless proliferation of cells, even after cessation of stimulus for growth which cause it. Leave about this definition what is on the screen. In simple terms, I'll tell you, every cell, the nature of every cell or every human being or every living being that is being born will have to die one day. Okay, in the similar way, even our the cells which are born will have to die one day, new cells will start coming up. That is the reason when you get a scratch on your skin, when something get injured, new cells will develop and then that wound will be healed. Suppose your liver keeps growing, what will happen? You will have an abnormal shape. But your skin cells, you'll go and cut your hair, you'll shape your beard, you do all this. Why? Because of the intention that you know that your hair will grow back and your beard will grow back. And you also know when you get injured, you are not scared. Just a scar will be formed, but still you know that cells will be formed. But do you know if something happens to your kidney and all? The damage is permanent. Okay. Only AK can be reversed, but if something happens, necrosis and all, it cannot be reversed. When some damage happens to heart or brain, what will happen? It will permanently get damaged. The function will decrease. You can only preserve the function, but you cannot get back the function. So, based on this, what you understood, some cells will divide. And when you do some liver transplant, what happens? When you really need it, the cells will divide. So, I have told you three concepts in brain and heart, skin and hair, and liver. So three types of cells are there. They're nothing but stable cells, labile cells, and permanent cells. Labile cells means what? Moving. Means continuously they are in division phase. Stable cells means they will also divide, but when they are necessary. That is like liver cells. Permanent cells are like when there will be damage it is permanently damaged. Something happens to your nervous tissue, that side will, opposite side will get paralyzed. It cannot be reversed, but you can prevent the further damage of the other cells. I think you are clear with this concept. Yes or no? Because every concept is clear, then you'll understand the class. Yes. Okay, very good. Remember, label cells, stable cells, permanent cells. And you know, every cell that is dividing means it is undergoing cell cycle. Okay? G1S, G2, M phase. Okay? So every cell is undergoing division means it is undergoing cell cycle. Okay? Remember that also. So, and you know that when now what happens? The normal cells are body cells. Cancer cells are nothing but we have discussed one definition, that abnormal, purposeless, useless cells. Means cells are undergoing cell division, but they're not undergoing complete division. That means in simple language, it's like a baby is developing in a mother's womb, but all the organs are not formed properly. So the baby which is being delivered cannot perform the functions as a baby which is completely formed and can perform all the functions during the course of lifetime. So you can tell that, you know, sometimes the babies get aborted, they do abortion, and also it's an incompletely developed baby, means it cannot perform all the functions. Suppose if baby everything is formed, but there is no function, there is a death of the baby. Means what? Cell is formed, but it's not useful. Similar way, cancer cells also are same. Normal cells which will divide are able to perform any function, but these cells will escape the growth signal. See, when something is cell is dying, you will get a growth signal telling that cell have to divide and form new cells. But in cancer cells, what will happen? Purposeless cells will be growing. Will be growing. They don't have any use. They cannot perform their functions. So these cells can be from any part of the body. Okay, these useful cells can be formed from any part of the body, either from your skin, either from your face, either in your lungs, either in your stomach, anywhere these cells can divide abnormally. Correct? So what will happen? There the tumor will form. Suppose if this tumor start, these cells will start shedding from that tumor or overgrowth, and it keeps dividing. Okay, it keeps sending to other parts, means it is going and sitting in other parts and starts growing. Okay, then it is called as metastasis, means the cancer has spread to other parts. So how you will understand which is primary tumor and which are metastatic? Because these cells are going and sitting there. Means what? When you take the biopsy and when you test the cells under microscope, you will have some stomach cancer went to some other place and sat, maybe liver or somewhere, and it started growing. So primary one will be stomach and metastasis will be liver metastasis would have occurred. Okay, that's how we will understand where is the primary tumor when you take out the biopsy and see those cells structure. Okay, I think you are clear with that also. You know that blood vessels will supply oxygen to all the parts of the cells and then it will give energy. In the same way for cancer cells also blood cells will be provided. If there is more and more blood vessels, then what will happen? There will be more and more oxygenation, more and more cells will grow. So you will, why I'm telling you all this, you will understand. Okay, hope you have understood. So the characteristics of the tumor and characteristics of normal cells is similar. Similar means what? The growth patterns. That is the reason what will happen. You are giving chemotherapeutic drugs to a patient. It means you are killing. There is something called as antimicrobial chemotherapy and anti-cancer chemotherapy. Antimicrobial chemotherapy here, what it means, there is some organism which is coming into your body and multiplying. External organism. And for that, you are giving some medicine to kill those organisms. That is called as antimicrobial chemotherapy. And what is this anti-cancer chemotherapy? Anti-cancer chemotherapy means your own cells are growing abnormally and you are giving drugs. That is nothing but chemotherapeutic drugs. Nothing but cytotoxic drugs, which will kill the cell. Cell lysis will happen. So you are giving drugs to kill your own cells. So both, and these drugs will act on different phases of cell cycle. Okay. Or sometimes it can act on all the phases of cell cycle. Okay. If they're acting on specific phase, they're cell cycle specific. If they're acting on all the phases, it's like called a cell cycle non-specific. It means that because of the similar characteristics of the normal cells and similar characteristic of the cancer cells, these drugs not only act on cancer cells, but they also go and act on labile cells. Labile means actively dividing cells. So that is the reason you will see so many adverse effects in cancer chemotherapeutic treatment. Are you clear till here, guys? Are you clear? Text me. Okay, good. Be attentive. And first of all, before starting about anti-cancer drugs, I would like to discuss with you different types of anti-cancer treatment. There are different types of cancer treatments available currently. There's but surgery, radiation therapy, chemotherapy, targeted therapy, immunotherapy, hormone therapy, precision medicine, combination treatment, like CAR T cell therapy, which has come recently, CRISPR, nanotechnology, and stem cell transplants. Okay, firstly, I will tell you about surgery. Surgery, why are we telling is the first option in cancer. See, some growth had happened, and when still it has not spread anywhere, it has clear-cut borders, you can cut and remove it. So that is the primary option and very easy. And if surgery is the best option, you go for surgery. That is the first treatment in solid tumors. And when you talk about radiation therapy means you will be giving radiation to certain part of the place where tumor has occurred. You can shrink the tumor to make it easily operable and then operate it. Or else you can give surgery and then give radiation. Sometimes, whenever, see, most of the head and neck cancers, you will go for radiation therapy. And chemotherapy means you are giving drugs to kill the cells. Targeted therapy means, so for example, I will tell you in very simple language, targeted therapy is nothing but something you're targeting. You know the reason for cancer is that kind of cells. Means you know the target. Suppose take for example breast cancer. In breast cancer, you know that estrogen receptor, progesterone receptor, HER2 receptor. HER2 means human epidermal growth factor receptor. So what will happen is these cells, these receptors are usually present in the breast tissue and they are responsible for the growth of the breast tissue. Okay, they are responsible for the growth of the breast tissue. If suppose there is mutation among these receptors, so what will happen because of the mutation? Suppose HER2 receptor mutation is there. So what will happen? More and more HER2 receptors will be generated. Which receptors? The one which has undergone mutation. It will become more and more. The tissue will start growing more and more. So what will happen? You will see the lumps. And when you see the breast tissue and when you observe under a microscope and you, after you take the breast sample, this biopsy, and after biopsy, if you send for IHC markers, mean immunohistochemistry, what are the receptors that have been expressed? And when you observe them, you using that reagents and all, you will find there are presence of HER2 receptors. Means you know the reason for the breast cancer, growth of the breast tissue in a female, in a female or male, okay, is the reason is HER2 receptor. So you have a target. If you go and kill those, block those receptors and those cells which are expressing those receptors, the growth of the breast tissue will reduce. Means you are killing those cancer cells. Means you know the target. Suppose you have done IHC testing and there is no ER positive, there is no PR positive, there is no HER2 positive. Means it's negative. You don't know the reason for breast cancer. So then treating a patient is, we don't know how patient will respond. Okay, understood in clearly. So targeted therapy means when you know the target and you have a drug which is developed against that receptor, it's very easy to treat. That is called targeted therapy. And immunotherapy is nothing but it will boost your immune system to fight against the cancer. Okay, it will boost your immune system to fight against that cancer. And everybody cannot receive immunotherapy. Okay. when some like a PD-L1 receptor expression will be there, percentage 10%, 20%, 50%. So when that expression is there more in a patient, then only this immune cell immunotherapy will have the target, sufficient amount of target. Then you can give that immunotherapy to the patient. So you have to check which patient is eligible, which kind of immunotherapy. In lung cancers and all, you give nivolumab, and in breast cancer, you give pembrolizumab, and you give pertuzumab, all this stuff. Okay, you have to check the eligibility for the patient. So immunotherapy is nothing but it will boost your immune system. Hormone therapy means hormone receptor cancers. Like, I told you about estrogen receptor, progesterone receptor, all this. Based on what kind of can be given, class of drugs can be given to patients after the chemotherapy and immunotherapy. They will have maintenance hormonal therapy for around 5 years or something. Okay, for the patients of hormone like testicular cancers like abiraterone acetate, all this you will be using as a hormonal therapy. Precision medicine means now you are like personalized medicines. So every patient is not same. Some patient will react some other way. This is nothing, you will have to modify the protocols. Combination treatment means you will give combination of surgery and radiation therapy or chemotherapy, targeted therapy and immunotherapy. Like dual targeted therapy also is there. Trastuzumab and pertuzumab, both are HER2 targets, but you will give them dually. Okay. And another one is you combine chemotherapy with radiation, chemotherapy with surgery. This is called as combination treatments. And CAR T cell therapy is now it's emerging. And now we have given two types of CAR T cell therapy, immune CAR T and immune CAR T for one patient, like multiple myeloma patient. And one we have given CAR T for one more patient who is PH positive ALL. We have finished the BFM 90 protocol, and later she was denying for chemotherapy. And as a maintenance, we have given CAR T cell therapy to the patient. Okay. After high dose chemotherapy will be given to a patient and then followed by CAR T cell therapy. It's nothing but an infusion. Okay. And you will have something called as you will be seeing so much of hypotension and all this after this, but usually we didn't see in our patients. Okay, gene editing and nanotechnology are still emerging and they have not given to anyone yet. And stem cell transplant like autologous and autologous stem cell allogenic. Autologous means what will happen is, I'll tell you in brief the procedure what happens. In stem cell transplant, suppose you take, I'll explain you one. Both are similar. Autologous stem cell transplant, what happens is initially patient will come for stem cell collection, the eligible patient. When the patient come for stem cell corrections, you will give something called as growth factors. So growth factors means which will stimulate your bone marrow to produce more and more cells. After that, you will give one mobilizer. Mobilizer means the cells, like plexifor injection and all, it is called as mobilizer. It will move the stem cells from bone marrow to peripheral blood. Okay. That you will give before the stem cell collection. And GCSF injection, the night before you will give in the morning. You will give two different doses of GCSF injections, growth factors, for the stimulation and more production of the stem cells in the bone marrow. And you will give mobilizer so that all the stem cells will move from the bone marrow peripheral blood. So using the mesh analysis machine, you will have something, you will be having a catheter in the central line, and from that will be inserted, patient will be sent for stem cell collection. Stem cell collection means they won't pierce your bone marrow or anything, because the cells are moving to the peripheral blood. From there it will be collected, stem cells will be collected and then stored. After that will begin high chemotherapy, very high chemotherapy, that your bone marrow will be completely. Other than what's there in your blood, your bone marrow is destroyed completely. Okay. After it becomes like that, you will his stem cells on day 6. Depends. Some patients will have high dose chemotherapy for 3 days, some will have for 2 days, depending on the type of cancer, depending on the type of patient, high dose chemotherapy will be given to the patient. After that, you will infuse his own stem cells. Means your bone marrow, you are getting all the stem cells infused. It's just like a normal blood transfusion. Sometimes we have 3 packets or 2 packets. Within 10 minutes or 15 minutes, however fast it is possible, we give the stem cell infusion to the patient in a very, very setup where, it's come, with therapy and all. After we giving it, patients who use the bone will not have WBC. So they're more prone to chance to infection. But it will take around 21 to 28 days in patients for the bone marrow to recover and for your bone marrow to start producing the own cells. Okay, during that time, patient will be chance of having so many side effects. So you will have to manage them with antibiotics and all this. Okay. And then when the patient's blood starts producing his own cell and reach some certain counts, platelets more than 20,000, 25,000, and WBC more than 2,000, and then HbA8, then we can discharge the patient and asking for follow-up. Okay. That's stable, we should be around 7 hours, the platelet about 20,000, and it will take 2 to 3 months for the patient to completely recover and for his bone marrow to produce. The same thing happens in allogenic also. And CAR T cell therapy is nothing but will go and fight against this. These T cells will be going and fighting against all the cancer cells and eating all the cancer cells. Okay, CAR T cell therapy is very simple. It's very expensive, but the infusions are very simple. It will not have so many side effects like how stem cell transplantation has. Are you clear, guys? Still here? I have explained you everything here in whatever is there in slides. Okay, very good. So you have to understand some terminologies, okay? I will tell you about these terminologies. Terminology is nothing but the curative and palliative treatment. What is this curative treatment? Means the patients can be cured completely of cancer. So the regimens which you are prescribing for a patient for complete cure is called as curative protocols and curative treatment. And palliative treatment means it relieves the symptoms and pain. Okay, just to keep a stable disease, to maintain, so to control the growth, that is called as palliative treatment. And surgery, I told you, preoperative chemotherapy, complete resection. So if you are giving what I told you in the combination treatment can be a combination of surgery plus chemotherapy. So what will happen? If the borders are not clear, it is not easily operable. You will give some chemotherapy or radiation therapy and shrink the tumor, and you make the borders very clear so that the tumor can be operated. That is called as neoadjuvant chemotherapy. And adjuvant means after surgery, you will be giving patient chemotherapy to ensure that there will be no recurrence. Okay? So that is called as adjuvant chemotherapy. Preoperative chemotherapy means drugs given to shrink the tumor before surgery. Complete resection means the tumor has been totally removed during surgery, as opposed to an incomplete resection. The surgical specimen may be. So what will happen after the removal of the um, this tissue or the tumor? What will happen, or the organ? Is complete breast means that one. Okay. MRI, modified complete removal of breast. Okay, radical mastectomy. So for that is for breast. For irrespective, then they will send this for pathologic examination. What is the reason for the cancer? Depending on that, they'll be giving maintenance immunotherapy or these things. Okay. Prosthesis, endoprosthesis is nothing. It's replacement, just for terminology. And endoprosthesis is fits inside the body, replacing the thigh bone. That's it. That is not related to chemotherapy, but for the terminology. And chemotherapy is nothing but it use of drugs to kill or slow the growth of cancer cells. I told you cytotoxic means you're killing the cells. Most type of cancer therapy will use number of different drugs. This is called as combination therapy. So it is given in different IV, IM, oral, intrathecal, topical, all this. Okay. Usually most of them are given IV, IM, and oral, and all the TK inhibitors are oral chemotherapeutic drugs. And intrathecally, you only give this in mostly hematology protocols. And for people who have CNS invasion, means where the cancer has spread to brain and all, you will give intrathecal chemotherapy. Okay. And topically, you will have very few will be using. Cytotoxic means which can kill the cells. Central line means Hickman catheter. Central line means you are giving, suppose there's something called as peripherally intrinsic central catheter, chemo port, all these things to deliver chemotherapy to ensure that multiple pricks are not there for the patient and chemotherapy can be given easily to the patients. And drug resistance means where these tumor cells become resistant to chemotherapy. That's why we will tell platinum resistant. All this means people resistant to platinum. Even after you give some cisplatin or carboplatin, the disease will not. They will have some stable disease, or there will be no change in the scan, follow-up scan. You've given 3 cycles, you've done some follow-up scan. There will be no difference in the size of the tumor. Means it is not decreasing, it is not increasing. There's some stable disease. Then you would call it as platinum resistant. Maybe after 3 months also it is happening like this. So you will have to rule out. That is why intermittent scans or intermittent tests are done during the treatments. Are you clear till here? So I told you about allogenic, autologous stem cell transplant, bone marrow transplant. I have explained you. See, the same thing is there. Once we finish these basics, I'll discuss with you so many cases. Okay. Guys, for anti-cancer therapy classification, if I go on read the drugs, it is very, boring. Okay. I will send you the PDF. Is that okay? Because you too can read out the classification, right? We'll discuss the cases, how we intervene. We'll have one good session. Okay. You want discussion or you want me to read out drugs? Drugs, so I'll send the PDF in group. You can go through the classification, which I have made. Tell me more discussion of cases or the drugs. Discussion. Okay, now you remember all the concepts. I'll make you tell answers. Okay. Okay, guys. Okay. Then listen to me briefly, all that stuff. We'll spend more time on discussion. So immunotherapy, I have already told you. See, immunotherapy is a type that helps your immune system fight by attacking the cancer cells. Okay. It is a sign of immune system responding to the tumor. Okay. Whose tumors contain tumor infiltrating cells often do better than people whose tumor do not contain it. That's what I told you. When PDL1 is depending on the percentage of expression, you will tell patient is eligible to immunotherapy or not and give it. Okay. See, different types of immune therapy, immune checkpoint inhibitors, T cell transfer therapy, monoclonal antibodies, treatment vaccines, immune system modulators. Usually, you will be using mostly immune checkpoint inhibitors and immune system modulators and monoclonal antibodies. Treatment vaccines and all we are not seeing in India, and T cell transfer therapies like CAR T cell we have. That's all. See, immune checkpoint inhibitors is nothing but don't think about this much. Okay. This is PDL1, which I was talking about. Depending on the expression of this tumor, this receptor, you will the immunotherapy to the patient. Okay, there is something called as Opdualag. That's nivolumab plus relatlimab. It involves 2 antibody drugs on the same infusion. One drug blocks the immune checkpoint LAG3 and the other blocks the P1. So when you're doing dual therapy, it will block all of them together and it will kill the cancer cells. Okay, don't think so much about this. Just remember what are the drugs. Okay. See, PDL1 binds to PD1 and inhibits T cell killing of tumor cells. Okay. See, this is the antigen. This is the T cell receptor. So what it will do? PDL1 will go and bind to PD1 receptors. Okay. And inhibits T cell killing of tumor cells. Okay. Blocking PDL1 or PD1 allows T cell killing of tumor cells. So when you go and block this T cell will be activated, and that means your immune system will get activated to go and fight against the cancer cell. Okay, then what will happen? Tumor cell death will happen. Did you understand this? Yes or no? So your drug is going and giving strength to your T cells or immune cells to fight against the cancer cells. Means your Indian army is getting support from US army to kill Pakistan. Understood in simple language? Okay. So don't see this diagram and get worried. Okay. T cell transfer therapy is nothing that makes them better to see this we are not using only. Okay. CAR T cell therapy, I have told you. CAR T cell therapy, I'll show you. See, CAR T cells is nothing but you want to know about this. Remove blood cells from the patient to get the T cells. Okay. You will take so how you take for BMT stem cell in a similar way. You will take the blood from the patient's body and then you will separate these T cells. So what will happen? You will have something called as CAR receptor. Insert a gene for CAR on the T cells and you will have some number. You have to culture those receptor using reagents. They will tell you this many number of cells should be cultivated. So the growth of millions of CAR T cells will be grown in the laboratory. Then after that, what will happen? The CAR T cells will be preserved under -26. If another CAR T was around -196 degrees centigrade, okay? Immune CAR T, which gave for multiple myeloma, we had a cryo shipper in which the temperature was there and it was around -196 centigrade. If you want about this, I have posted on my LinkedIn. You can read about that immune CAR T and all. Two posts are there about different CAR T cell therapy and tocilizumab why we give to print adverse effects. You can please guys go through my LinkedIn this thing. You can read about it. I've posted. So because we don't have much time. So I will just give an infusion of this cells. These cells, CAR T cells, will go and fight against cancer cells and eat them. Okay. And they'll act for long term. And the therapy would cost around 45 lakhs for CAR T, minimum 30 lakhs one CAR T and 45 lakhs to another CAR T, depending on the type of CAR T cell therapy. Very expensive, but the packet looks very small. I think you can even see the photographs of how we have given CAR T cell therapy in my LinkedIn. Okay. Is it okay? Shall I go ahead? Shall I go ahead, guys? Okay. Yes or no? Very good. So monoclonal antibodies are nothing but rituximab. Suppose if you have CD20 expression, cancer. See, suppose you have Hodgkin's lymphoma, non-Hodgkin's lymphoma. In non-Hodgkin's lymphoma, what will happen is patient will have expression of CD20. When the patient has CD20, you will have a targeted rituximab at CD20 and antibodies. These are nothing but they are being grown and cultured. They're prepared in the laboratory. That is why you call them as they are also immunotherapy because they help turn immune system turn against cancer. Okay. And these are also targeted therapy also. They target against CD20 cells. And these monoclonal antibodies are synthesized from a mutant source or a rat or, humanized. Humanized means from the human they will be culturing. So these are all done in the lab. Okay. Chimeric antigen receptor. Okay. That is a protein that you will go and attach to these T cells. Means your own body T cells. See, T cells will fight again. Are the T cells are nothing but these T cells are the one which will the immune system cells. Okay, it'll go and fight against any infections or anything that in your body. So to strengthen the immune system, they'll induce a receptor. Because of this receptor introduction to the T cells and giving growing millions of those T cells means for your immune system is getting boosted and this T cell CAR protein which was introduced on T cells and those T cells which are cultivated more and being given back to the patient will have the power to go and kill the cancer cells. Okay, such protein will be incorporated and grown means you have some people which are given, see, your own people who got trained in shooting the guns. Okay. Suppose what is happening, US is taking the Indian army there and training them to use the advanced weapons and sending them back to you. So they're giving you more energy. These soldiers which have been trained well in US army are coming back to India to fight against Pakistan. So than the people who knows only the use of certain weapons, when they get add on with the people, means your own Indian people who are having more and more knowledge and more talent and power are giving strength to Indian army to kill Pakistan army. Clear, guys? Aryan, are you clear? Yes, on the T cell, you are attaching a protein CAR, which will boost your immune system to go and kill the cancer cells. Okay. So clear? Everybody clear? No doubts? We'll go ahead. Yeah, you have more thing, you can read on that and you can ask me doubts in group also. Okay? Very good. See, these are T cells, these are cancer cells, these are monoclonal antibody. So it will go and kill. See, monoclonal antibody is there, antigen protein on the cell that can cause the immune system to respond. The monoclonal antibody locks onto the antigen. This can cause the immune system to attack the cancer cells. So if it is an antigen, that is CD20, which is being expressed, the drug will go and block that. When that is blocking, what will happen? The T cells will come and eat this cancer cell. Okay. Treatment vaccines are nothing but, see, a type of immunotherapy that treat cancer by strengthening body's natural defenses against cancer. Means these are used to treat people who already have cancer. Okay. Oncolytic virus therapy, uh, it will cause infection to cancer cells, but it will not harm the normal cells. There is some example, talimogene, leherparavic. Okay. So it is based on herpes simplex virus type 1. Although this virus can infect both cancers and normal cells are able to kill the virus. Cancer cells cannot kill this virus. So it will go and attack that one and kill the cancer cells. Our cells will kill the virus. Okay, but cancer cells don't have the potency to kill because I told you they cannot perform all the functions. So because of this vaccine, what will do? It will go and kill the cancer cells. See, it is directly injected into a tumor. As the virus makes more and more copies of itself, it causes cancer cells to burst and die. Okay. Our, our body cells can kill this herpes one, but cancer cells cannot because they're abnormal cells, they cannot perform all the functions. So this virus will go into cancer cells and continuously multiply and kill that cancer cells. Okay. And Sipuleucel is another vaccine. It is used with prostate cancer to prevent it from spreading to other parts of the body, and it will be used only in patients whose cancer does not respond to hormone treatment. Okay, immune system modulators are like cytokines, interferons, interleukins, erythropoietin, GM-CSF. This is nothing but granulocyte, monocyte, colony stimulating factors. We discuss about this, and BCG and immunomodulatory drugs like thalidomide, lenalidomide. You use these drugs mainly in multiple myeloma patients. Okay. You see the use of, but yearly, usually we are not using thalidomide now. Usually we are using lenalidomide and pomalidomide. Okay. And targeted therapy, I have explained you. Okay. They're nothing but small molecule drugs. Small molecule, see, targeted therapy are two types. There's under small molecules and monoclonal antibodies. You saw when I showed you monoclonal antibodies, they're going in binding on the cell. On the cell. Small molecule inhibitors are nothing but they'll go inside the cell. They'll penetrate inside the cell and they'll act. Okay. I'll send you the classification, then you can read. It's very easy to understand. Or I'll show you the classification in between. Targeted therapy, I told you, help the immune system to destroy the cells. So some will stop the signals. Okay. Um, and some will deliver cell killing into the cell, cause cancer cell death, starve cancer for hormones to grow. You have big classification. Okay. See, your targeted therapy may work best when used with more than one type of targeted therapy. That's what I told you. You'll give pertuzumab and trastuzumab, dual targeted therapy. Both will act against in breast cancer. That is the meaning of this. Okay. Now we will see. Till here, any doubts, guys? This is very much interesting now. Okay. See, I have sent you classification in the group. Did you get it? Did you get it, guys? Yes or no? Did you see in the group I have already sent? So you can see about the different types of drugs and you can read. Very good. Now we'll see about principles of chemotherapy. These are nothing but these principles are the fundamental concepts that you people should know, which will guide in effective and safe use of these anti-cancer drugs. And these are based on tumor biology, means how the tumor is growing, what is the characteristic of the tumor, whether the cells are dividing continuously, or if the growth of the tumor is very low, the speed, the mainly the growth. Okay, growth fraction is very low. All these are very based on the drug pharmacology. What is your therapeutic goal? Palliative, curative, all this, it depends. So what is this one? Growth fraction is nothing but growth fraction means for every second how many times the cell is dividing. Okay. And you know that chemotherapy, I told you, it will act against actively dividing cells. If the growth of the tumor is very fast, then if you give chemotherapy, it acts very well. And if the growth of the tumor cells is very slow, if you give chemotherapy, it is not useful. So you have to wait. Because when you don't have enough number of cells, cancer cells, and if you're giving chemotherapy, you will have more adverse effects when compared to useful treatment. Okay, that is why all these are very important. And there's something called as cell cycle specificity. I told you there's something called as cell cycle specific agents and non-specific agents. Specific agents like antimetabolites and also Vinca alkaloids, they act in M phase, and something called as non-specific agents means they act on resting cells also, dividing cells also. Means it can act on any phase of the cell cycle. So there is another thing when you are giving something called as dosing, scheduling, all this, okay, there is something called as sequence of chemotherapy. Suppose you are giving paclitaxel and carboplatin. Paclitaxel is a taxane, okay. It will act against one specific phase of cell cycle, and carboplatin is non-specific. So when you are giving the combination, you should always give specific drugs first. Okay, because you are acting only in one place. So if you give the drug, it will go and kill all the cells which are in that phase. Okay. And later, what will happen? If you are giving drugs which will act on all the phases of the cell cycle, then it can go and act other than that first one which acted on specific phase, remaining phases, it can act more. Suppose if you are giving a drug which will act on all the phases of the cell cycle first, and then if you give a drug that will act on a specific phase, you will not have that cells that much count because this drug would have already killed those cells which are even in that phase. Now you understood the difference? Yes or no? Yes, are you clear with this? Okay. Next one is tumor burden. Actually, small tumors are more responsive, because of high growth fractions. When the tumor is small, when the growth rate is very fast, what will happen? These will respond faster to chemotherapy. Suppose the tumor is big and growth is very slowly, they are dividing. They don't respond faster, better to chemotherapy. Okay. There's something called as log kill hypothesis. Very small, I will tell you. See, there are 100 cells. Okay. If first you are giving some 20 mg of drug, it will kill what? It will kill around 20% of cells. And again, next cycle you will give. How much it will give? Suppose from 100, it will kill 20%. Again, you have some 80 cells. When you give next time drug, what will happen? It will kill 20% of 80 cells. Then if you give 60, then it will give 20% of 60. It will kill in fractions, but it will not tell like, okay, if you give first chemotherapy, if it is 100 cells, from next, after first cycle 20 mg dose, 100 become 80, and second dose, 80 become 60. No, 80 won't become 60. 20% of 80 will be killed. Irrespective, it is more than that also. Are you clear with this? The percentage of the cells will be killed in each cycle. Slowly, slowly, the cancer cells will come down. Fraction of cells will be killed rather than number of cells. Okay, that is Locke's hypothesis. That is what will be followed. So multiple cycles are needed to progressively reduce tumor cell population. What is the cycles? You will not give repeatedly chemotherapy because they're narrow therapeutic index drugs and your blood levels will, and you have so much of toxicity. You need your body to recover of toxicity. So you will not give so you have schedules for chemotherapy. You will say 21-day cycle, 7-day cycle, 14-day cycle, 28-day cycles. Different chemotherapy will be given in different cell cycles. Okay, combination chemotherapy. What is this combination chemotherapy? You will have to, if you are combining two drugs, two chemotherapy drugs, you can't give cisplatin, carboplatin from the same class. Okay, you have to combine drugs. You have to ensure that the drugs are having different mechanism of action and non-overlapping toxicities. Means they should not have similar toxicity. Maybe they will have, but the percentage of toxicity caused by the combination drug should not be more intense. Okay, like two platins you will not give. See, Paclitaxel, they are different mechanism of action. The toxicities are different. And you have to see that cell kill should be synergistic or additive. Means they should kill more cells, cause less side effects, and they should have different mechanism of action. That's how you have to choose the therapies. And mostly everything is decided based on guidelines, and all this are given in that way only. Okay. So the what will happen when you're giving different class of drugs, it will reduce the resistance and improve the efficacy. Okay. What is this dosing and scheduling? Higher doses may improve efficacy, but it will increase toxicity. Dose intensity means within short intervals. Suppose if your tumor growth is very, very, very fast, what they will do is they will reduce the intervals and dose also. Okay. They will give like weekly chemotherapy, they will give dose dense chemotherapy in a way that they will balance. See, in people with cervical cancer, they will give Paclitaxel in weekly cycles. And the dose will be less, but the period also will be very shorter intervals because the growth rate is very fast. So they will respond very nicely. So that's how the dosing and scheduling is done. And they will have to balance the cell kill, and patient should have acceptable toxicity, and also they have to recover. And resistance means primary resistance means tumor is already resistant. Acquired resistance means it will develop during the therapy, during the course of therapy. What will happen? There will be drug efflux pumps because mutations will happen in the efflux pumps. So what will happen? Whatever the drug is being taken will be sent out. So the drug cannot act in the cell. So that's how also resistance will be there. So we have to prevent resistance, including combination regimens and early aggressive treatments. Means initially only you have to give aggressive treatments. So when you're giving repeatedly same drugs, what will happen? Your tumor will become resistant. So you have to see which regimens are used. That's why they will be called as first line treatment, second line treatment. If first line fails, then you'll go for second line. Toxicity and therapeutic index. Actually, chemotherapy will affect this normally dividing cells. Means they're like bone marrow, GA tract, hair follicles, I was telling you. So because they're also continuously dividing cells in our body, so the drug will affect those cells, and so you will have toxicities. Okay. And you have to maximize you have to give more, cell kill should be more, adverse effect should be less. And I told you about adjuvant and neoadjuvant chemotherapy. So you will have to see which, like adjuvant chemotherapy is usually given to prevent to eliminate micrometastasis. Micrometastasis means during surgery, maybe one or two cells would have been left out that cannot be observed under the PET scan. PET scan is nothing but positive electron emission tomography, where you will be given FDG, fluorodeoxyglucose, for a patient, and you will be kept overnight fast, and morning by checking the creatinine levels. The patient will be taken for scanning, and wherever the tumor is there, this FDG uptake will be there, and then this will start glowing in the scan. So what you will see, wherever there is a tumor, means whether it has spread to the whole body or not, you will observe. Okay, that's how you will see whether anything is there. But some cells cannot be even diagnosed, can be seen in the PET CT. That is called as micrometastasis, because at least you need some certain amount of cells to be observed in the PET CT scan. Okay, based on that, it will be there. Okay, next one is monitoring response and adjusting therapy. So regular assessment using, we have to, in between cycles, I told you, you will have to check with the imaging, tumor markers and clinical status. And you will have to modify the doses based on response, toxicity and emerging resistance. Okay, guys. Okay, are you clear till here, guys? Did you understand? Any doubts? Afia, what did you understand? I'll explain. You tell me. You'll understand when I teach you the case. Okay? Any doubts that you didn't understand? You can type me here. Tell me what you didn't understand. Okay, I'll explain. Afia, I won't forget you. Maybe I'll forget your name. Please ask me doubt in the end of the session. Okay, I told you about, see, some concepts like curative chemotherapy means to achieve complete remission, means complete, destroy the cancer cell, and also to prevent the recurrence. You will have maintenance therapy. Adjuvant means before surgery, adjuvant means after surgery for micrometastasis, and new adjuvant is before surgery. Palliative means just to extend life and reduce to improve the quality of life. A salvage means given to when no other options are exhausted, means all the other options are exhausted, you don't have any other thing. We'll just give it for maintenance, just to maintain the patient, but it's in final stages. Concurrent means you will get along with radiation chemotherapy. Means if you're giving 5 days, there's something called as out of week, there are 7 days. For 5 days, you will give radiation to patient, and 2 days you will leave the patient. That is called as radiation free days. Okay, that is to help the normal cells to recover from the effects of radiation. And among that 5 days, you will give chemotherapy to a patient, very low dose chemotherapy to increase the sensitivity of radiation. Okay, guys, are you clear with this? Okay, for protocol optimization, you will have something called as baseline blood reports prior to every cycle. You have to check the heart function for the drugs which will be effect on the heart, like adriamycin and all this. And for some drugs, you have to do CBC, LFT, RFT. Why we are doing complete blood counts? You know that I will tell you. You will have to tell me the answer during discussion. Why all this is organ function status, ECOG status, ECOG is nothing but performance status, whether the patient is bedridden or patient can perform his daily activities, all these things. Okay, 0, 1, 2, 3, 4 are there. You can just go and see in Google ECOG status. Okay. Next one is type of treatment, whether it's palliative, curative, adjuvant, comorbid conditions means whether the patient is having diabetes, hypertension, all this, and adverse effects after each and every cycle you will have to check. Why we have to check, I'll discuss you in the case. See, this is nothing but administration of vincristine drug. You know, vincristine is a highly extravasant drug. It will go and come out of your blood vessels. Suppose if you have to give IV push of vincristine, if you directly give, what will happen? There is a chance that the drug will leak into blood vessels and it can damage the tissue. Okay, and it will harm your blood vessel veins. So what you will do? This is called as running energy. This is two-way. Okay, in this three-way, what will happen is from this side, NS will be running continuously, and from this side, you will give slow push of vincristine injection. Maybe 1 ml, you will dilute 2 ml, and then you'll start slowly pushing. So, what will happen? And now, anyhow, running NS is there. In that, you'll push the drug. Afterwards, remaining 100 ml will run, and then it will clear the drug out of veins, and you can prevent extravasation of the drug. This was the intervention I have done during my when I was a clinical pharmacist, until now, patient didn't have any single extravasation. Okay. And you know, from diagnosis, treatment decision, and treatment planning, the first thing is patients have right to educate. As a clinical pharmacist, you should know that you will play a very important role in educating the patient during administration, prior to administration, and during management of each and every cycle. Okay. That is the thing we need to discuss right now. And you should know that uh, chemotherapy or cancer therapies is not from a single person. Okay, single doctor will not treat you. You will have a multidisciplinary team where you have oncologists, radiologists, pathologists, clinical pharmacists, nurses, social workers, psychiatrists, patient navigators, physiotherapists, dietitian. Because diet is very important in cancer. You have to know what kind of diet, what can be taken, because you know patient will have different side effects or adverse effects. So you have to tolerate chemotherapy. You need energy. So the dietitian plays a very important. Oncologist have to prescribe the treatment. Radiologist, because they have to interpret the scans. Pathologist, you have to check your samples, tissues, all this, and you have to take the biopsies. Clinical pharmacist, very play important role and patient counseling, reporting adverse drug reactions, treatment and monitoring, dosage adjustment, all this. And nurses to administer the chemotherapy. Social worker will have to coordinate with all the things. Okay. Psychiatrist, because mentally patient will be already emotionally down when he gets diagnosed with cancer. So you need a psychiatrist. Patient navigator means it means you will have so many procedures in insurance. You need to get any free drugs, patient assistance programs, all these things. So you need somebody needs to guide you and somebody needs to inform you about everything. And for that, you will have a patient navigator. And physiotherapist, sometimes you will have be complaining of different pains. And you know, somebody need you be having leg pains, you'll be having hand pains, body pains during the course of treatment, and you need some exercises. So all that physiotherapist will help you. And dietitian I have already told you. So it's a coordination from the all the people, different departments to ensure patient is having very good quality of life during the course of his treatment cycles. Are you clear, guys? Okay, very good. See, so, okay, I'm only talking. Now, okay, now we'll have more interactive session. Okay, I'll ask you something. See, everybody love counseling patient, yes or no, as a pharmacist? So everybody will ask me, ma'am, everybody will tell clinical pharmacist have only one role, patient counseling, patient counseling. Suppose if I am posted in oncology, I also want to go and counsel, ma'am. So I'll ask you one question. People tell me yes or no, okay? I'll tell you something. If somebody is posted in a OP counseling center and ask you to counsel regarding something, you know, accept this, okay? How many of you do this? You'll have one list of medications and you'll have a prescription. And what counseling everybody will do? Sir, ido morning one, afternoon one, night one. TID means morning one, afternoon one, night one. After food, before food. Okay? Yes or no? That is what the counseling we do now. Tell me truth. Correct, na? Because you know only that much. That much only you are taught. You have to make so many forms, you have to make up so much data. So whatever is there, morning, afternoon, night, before food, after food. That's all, nothing else. Correct, na? Array, it's a role of pharmacist, but I'm telling you how you should counsel. So when you come to chemotherapy, if I give you, I'll tell you before the patient starts with his treatment, if I give you this questionnaire, read out. Everybody read out for yourselves. Once you are done reading, just message me, done, madam. Don't take more time, yeah. We need to discuss cases. Yes or no? Have you read? Done, no? So when I'll tell, okay, Saundarya, Kirti, Prashanti, Sumaya, Afia, okay, all of you go and do counseling for a patient. So you would introduce yourself and you will start telling the patient whether, first of all, you should also know, you should all, when they prescribe with the treatment, what you will do, you will go and tell, okay, ma'am has given the checklist. So you will start sitting with the patient and you will start telling, what is chemotherapy? How does it work? How is chemotherapy used? Why you are having chemotherapy? Okay. If I ask you to counsel, now is it easy for you or not? Can you provide? This is all the information patient wants to know. Even before he asks you a certain question, if you are explaining, answering all these questions, will the patient be satisfied and you have a complete answer for your questions? Yes or no? Yes or no? So you should be trained on knowing these definitions and every chemotherapy. Chemotherapy means a certain definition. Why you are giving chemotherapy, how chemotherapy is used, means whether you are giving IV, whether you're taking oral. If you're in a regimen, you have one IV, one oral, everything you are explaining about each protocol, these answers will be different. But most of them will be same. When you explain them in complete language, in this treatment cost and all, you will have people to counsel, different people. But if the patient gets answer for all these questions, does he feel motivated? Yes, right, guys? So when I give you a questionnaire like this and ask you, you will do it. Yes or no? What would I? What doubt you have? No. So this is what. Next. Remember these questions. Okay. Now we will discuss all this when you're going to a case. So you should ask about fertility, like preservation or anything, sperm preservation, all these things. Pack a chemo bag. Chemo bag is nothing but suppose if you are going to a hospital, you'll have to wait for long hours in the queue. Sometimes drugs to be invented, procured, administered, mixed. So in this process, it will take time. You just can't sit there, right? So in your chemo bag, you should pack your lunch box. You put some magazine, newspaper, whatever is required, so that you have to sit for 4 5 hours in the hospital. Simply boring. Pack your earphones, pack your mobile. So all this. You should look at yourself, look after yourself, whether you can take care of yourself, you need an assistant with you. And suppose if you cannot do, you should ensure that somebody is there with you at home, because of the so many side effects, you need somebody help at home. And you should discuss your patient should discuss his or her concerns with us. He should tell, ma'am, I don't have any support. Everything he should discuss. He should, if he's a job employer, he have to discuss with employer, maybe checking for leaves or giving him work which is very lower. Patient should check their oral hygiene, because more chance of mucositis and more chance of infections. You should be prepared for the side effects, and also check on other medications that are required. Yes or no? Did you understand? Correct? Understood? Okay. Okay. So something like this. Posters are very important. If you smoke, try to quit before chemotherapy starts, as smoking may affect how well the treatment works and make side effects worse. Quitting can be difficult, especially if you're feeling anxious about the cancer diagnosis and treatment. Some posters like this. Okay. Next one. So, patient education awareness, treatment related. So, treatment related education. First, you told about chemotherapy, how it will be given IV, all this you have explained to the patient. Now you have to tell you have so and so drugs given for each cycle, and these many you will be receiving 6 cycles of treatment. And so, what can be expected during treatment? What side effects? So, what are the different types of that you will be receiving? You will be receiving IV chemotherapy plus oral. You will be receiving all IV chemotherapeutic drugs. So, chemotherapy with other treatments. Other treatment, maybe patient is going on any other treatment. Maybe you'll be requiring endoscopy, or because of the side effects, or other treatments, ongoing treatments. Maybe he might be receiving his medications for other comorbidities. How it will affect. So, waiting for chemotherapy. When you have to wait for chemotherapy, what all you can do, what are the safety precautions, how you'll understand whether treatment is working on it, like follow-up scans and all, how to manage side effects. All this you have to give awareness to your patient. Now I am giving you the list. So it will become more easy for you to counsel the patient and when you know about how the drug is used. Okay. So there's something called as toxicity and late effects. Acute means the side effects are seen instantly for a shortened duration. Sometimes they will be worsening. Sometimes they will be reversing, means sometimes patient will have vomiting and it will reverse after 2-3 days. Chronic means long lasting. Immunosuppressive means so if you have severe doses or more, it will give more bone marrow suppression, means more WBC or less. So neutrophils are less. So what will happen? You will have more chance of getting infection. Okay. Patient will have fever also. Fever is one way that a patient will respond to the side effect. So how you will toxicity gradings means there's something called a CTCAE grading. Common toxicity criteria for adverse events in oncology. Ma'am, after answering those questions to the patient, he or she would be satisfied, or in reality, he or she would be frightened more. See, it depends on the way you counsel. You go and tell this will be given. So you how the way you counsel. See, RN, I'll tell you an example. Suppose patient is taking paclitaxel chemotherapeutic drug. I'll tell you how I have counseled a patient. Okay, you'll understand. See, these are the most common side effects. Yes or no? See, feeling tired because you're giving high dose of drugs, you will have lack of energy. This is nothing but fatigue. What is this fatigue, ma? Why these people are having fatigue? Hmm? It's a very, very common side effect of chemotherapy. Okay. See, feeling tired and lacking energy is called as fatigue. And it's a very most common side effect of chemotherapy. It means, like feeling exhausted, drowsy, confused. All these things are the symptoms of this. It can appear suddenly and be taking rest also may not relieve that fatigue. And you still feel very tired and weak for months sometimes, okay? Sometimes patient also will go in depression because of this fatigue. Another one is appetite changes, nausea and vomiting. It's very common for your appetite to change when you're going through chemotherapy, when a patient is going through chemotherapy. And the drugs will also change the taste of food. Sometimes the patient will not feel hungry, and they'll be preferring different types of food. It will make you nauseated. Nausea means if you nausea means you won't feel like eating anything. That may be accompanied by a vomiting, and patient may not vomiting. Only nausea sensation he may have. Okay. Constipation and diarrhea. Some will cause, some pain medications like Ultraset, which is given for a patient, will cause, constipation. Okay, and some chemotherapeutic drugs like gemcitabine also will cause constipation. When something is not digested and when somebody don't pass loose stools, how uncomfortable you will feel. So irritated, everything, all other symptoms are developing. And hair also. So you will tell them, the hair loss will be there. You'll have to counsel them to put some cold cap or something, to reduce the blood flow, and then the amount of chemotherapy that reaches the scalp will be very less. So all that cannot be done. And mouth sores, with ulcers or infection. So this will be seen in patients who mostly have radiation therapy of head and neck cancer and chest. They'll have so many dental and gum problems. So you'll have to discuss. Sometimes you have to take 1 tablespoon of bicarbonate soda, put in glass of warm water, and then you'll start gargle and spit it out. Usually you have to avoid mouthwashes that contains alcohol. Okay, you have to sip fluids, especially water, and eat moist foods if they have dry mouth and all this they'll have to do. You'll have to counsel the patient and you have to tell them to avoid smoking and alcohol drinks, very hard foods and spicy foods. And thinking and memory changes, we'll have to they'll have difficulty in concentrating and focusing and remembering. This is called cancer related cognitive impairment. Sometimes it's called as chemo brain. Okay, or cancer fog. Thinking and memory changes may be caused by treatment or medicines, like so much fatigue, sleep problems, emotional concerns, stress, and depression. Then this will improve with time. Okay. So, and infections will be like if your blood cells drop, you will have the total white cell. That is the reason for every cycle you will have to monitor patient blood counts. Okay. And bleeding problems, when platelets will come down, you will have bleeding problems like thrombocytopenia. When you're giving mainly this, you will see in high dose cytarabine and all when you give patients with AML and all these things. And changes in hearing, like some drugs like cisplatin, all this cause ototoxicity. And sex and fertility is like can have impact on the desire or ability to have sex. And also it will affect the sexual organs and functioning in men and women. Okay. And in chemotherapy can reduce levels of hormones produced by these ovaries. So for some women, there'll be regular periods, but they return to normal after treatment. Sometimes it may cause menopause. Sometimes they cannot have children. So what are the symptoms of menopause? Like flushing, sweating, flushes, dry skin. Mainly menopause occurs for women who are under 40 in the long term. And their bones also become weaker. Okay. And for men, the sperm production also will be less. And this infertility may be temporary or permanent, that you cannot tell. Okay, it depends. So you'll always have some cancer support for these patients. Are you clear, guys? Yes or no? Have you understood? If you have understood, then we'll go. You will have so many like chemomany, how many adverse effects? Hemorrhagic cystitis with cyclophosphamide, bleomycin, see bleomycin, pulmonary toxicity. Okay. Vincristine, like here you can see peripheral neuropathy, doxorubicin. You see heart, dil, cardiotoxic, doxorubicin, daunorubicin, all this. And doxorubicin, you will have so much of alopecia, all this. Okay. Now we will go somewhere. Okay. And I'll tell you guys, people will be getting doubt. Ma'am, we have treated cancer. Okay. Yes or no? We have treated cancer. Why cancer is coming back, ma'am? Why? Something called as stem cells? Yes or no? Yes or no, guys? Yes or no, fast. So, stem cells have the ability to produce any kind of stem cells. Okay. So, what will happen when you have stem cells you have stem cells for every organ? Okay. What these stem cells will do is stem cells. I'll show you. See this picture. Now you'll understand. Cancer stem cell characteristics. Minor population in tumor is 0.1 a few percent. They have the characteristic of self-renewal. Okay. Enhanced resistance to drugs, radiation, because cancer stem cells have not turned up to any kind of cells. So you don't know which to give and target them. Okay. So what will happen? You are killing cancer cells, but you are not killing cancer stem cells. So when your immune system becomes weak, these cancer stem cells can they can become any types of cells and they can increase the tumor growth. That is why you will see relapse. So now in cancer is why you are killing cancer cells, you know what kind of cancer it is. You're having some treatment, you will kill. You say stomach cancer, lung cancer, liver cancer. So you know which types of cells are multiplying and you're giving the cancer cells and reducing the tumor or killing the tumor or something. But cancer stem cells, we don't know to which kind of cells it will become. So they have self-renewal. So that is the reason you will get relapse. So strategies to eradicate cancer stem cells are an adjunct topic in cancer research. Have you understood, guys? When these cancer stem cells will start becoming more and more and they start becoming cancer cells, it will become relapse. That is the reason you cannot tell, doctor told cancer won't come back. Means according to what he has treated, it is not coming back. But if your cancer stem cells are multiplying, what can doctor do? Correct. That's why you don't understand what will happen, when it can happen. It can relapse, it can be controlled. That is why your immune system will be stronger. So these immune checkpoint inhibitors, all these drugs, immune system related drugs will help in boosting the immune system. That's why you will give 17, 18 cycles of these immunotherapies to make your immune system strong and prevent the relapse and recurrence. Okay. Now, your interesting part, supportive medications. Ma'am, what are these supportive medications? So, we'll have some icebreaker activity. Yes or no? Yes, guys. I'll ask you a few questions now. You'll answer me. That is what Aryan is on research. That's why CAR T-cell therapy is also there. Not cancer disease, but actively to fight. You only can only boost your immune system. We cannot tell. Okay. Icebreaker activity. Okay. Now become alert. Why should you give supportive medications? One by, let's have a discussion. Why should we give supportive medications to a patient? One line answer. Come on, guys. Why you need supportive medication? Very good, Fernandez, to reduce treat side effects. Okay. What kind of side effects you want to treat? CINV, very good. Chemotherapy induced nausea and vomiting. Yes, chemo induced. Yes, very good. So, very good. Not resistance to treat the side effects in simple answer. So, we have seen all the side effects, right? We have seen vomiting, we have seen diarrhea, we have seen. So, you know that specific drugs will cause specific side effects. Suppose you are saying adriamycin, cyclophosphamide, you are giving to a patient. You know it will cause so much of toxins. You'll have hair fall. Hair fall you can't treat anyhow during the treatment because it reverts. You will have so much of bone marrow suppression with the drug. So there is a patient have more chance of depression of bone marrow. So you are giving some support after 24 hours of the chemotherapy to boost your bone marrow, okay, to produce more and more blood cells so that patient will go not going to neutropenia. What is that support medication called as? You have seen one word GM-CSF and GCSF. Nothing but they are granulocyte, monocyte, colony stimulating factors. You know, blood cells do not divide into one cell will not become two. They'll be produced from their precursor cells. So you are boosting those granulocyte, monocyte, colony stimulating factors. Colony means the colony which will produce the three different cell lines. RBC, WBC, okay, myeloid progenitors and lymphoid progenitors. So you are boosting those precursor cells to produce more blood cells so that the patient will not go into neutropenia. You will be giving these with, high dose chemotherapies, adriamycin, cyclophosphamide, all these combinations of chemotherapy. And patients who are having, diabetes and also like who have more chance of going to neutropenia, you will give this support. Understood about this? Yes or no? Next one. You know that chemotherapy will cause so much of nausea and vomiting because even your GI cells are also actively dividing cells. So there will be effect on your gastrointestinal system also. To prevent vomiting, what you will do when patient get discharged after chemotherapy for 5 days, you will be prescribing with some ondansetron, perinom, all these things. Mostly ondansetron for 5 days. TID you will be prescribing for a patient to prevent the vomiting and to ensure that only nausea means to prevent the loss of appetite and all this. And you will give pantoprazole to avoid that acidity because of high dose of drugs. So that is over. Next, another side effect is diarrhea. Some chemotherapy like irinotecan, 5FU, they have more chance of causing diarrhea. So in their discharge medications, along with pantoprazole and ondansetron, you will have to give patient with lopermide, okay, to decrease the gut motility. Means more than 3 loose stools, patient can take one loperamide 2 mg and maximum he can take it for 4 times in a day. And if it is more, you will have to report back to the physician and you have to counsel the patient based on the drug. You have to tell them to have buttermilk, with salt to put in it, because when so much of loose stools and happen, there will be deficiency in electrolyte imbalance. So that you will have to counsel the patient. Okay. So if some patient is having gemcitabine cisplatin, you will have constipation. So you will tell patient to take cremofen if they're not able to pass stools. These all are the supportive medications that you will include in a discharge summary for a patient before leaving from the hospital after every cycle. And you will tell them not to worry. If they face such side effects, you can take these medications for the preferred amount of time. Suppose you see paclitaxel and all, these are will call, neuropathic pain, like pricking pain and all. I told you, it's peripheral neuropathy. So you will prescribe them with pregabalin 75 mg ODHS at night. Initially, you will go with Altracet, and if patient does not subside and depending on the grade of toxicity, you will start with pregabalin. And there's something called as Hafus cream, oxaliplatin and this, capecitabine in capox regimen in like stomach cancer and all, patient have more chance of discoloration of hands and feet. Like it will become blackish. So that you will suggest them with the Hafus cream and you tell them to avoid cold. So depending on for every chemotherapy, you will have, anti-emetic medications, antidiarrheal like for constipation, for vomiting, and for acidity, you will have the common medications. In people is more chance of having loose stools, you will have antidiarrheals, and after the cycle, you will give them with folate and vitamin B12 strips so that patient will not get decrease of folate and vitamin B12, mainly with the patients who are having methotrexate and the folate antagonists and all. And you will be sometimes giving multivitamin and B12 infusion before the start of chemotherapy as a prehydration so that the deficient nutrients and vitamins will be there back in the patient. These all are supportive medications. And GCSF. Sometimes I told you that patients with chemotherapy below 40 years of age will have some bone resorption and all. For them, you will have zoledronic acid. Okay. And some patients you will be giving octreotide, like when like neuroendocrine tumors, when more and more hormones will be produced and they will have you will have problems because of that. Okay, there you will be giving octreotide and all to the patients. Then because of this in patients with and mainly because when the tumors, where you have some tumors which will produce more hormones, like prostate tumors and all these things. Okay, like carcinoid tumors, gastronomas, in the to suppress insulin secretion, all this somatostatin analog it is. Okay, that will be there. Have you understood about the supportive medications? And sometimes mucositis will be there. Sometimes you'll give lignocaine, and sometimes patient have severe pain. Then you will give morphine. Okay. Are you clear with supportive medications? Okay. I'll tell you something. See, some case, okay. A 64-year-old. Don't think about other PET CT reports and all. Just see how we have done intervention. A 64-year-old female who is a known case of breast cancer. Patient came to receive cycle 4 chemotherapy with adriamycin cyclophosphamide. She started complaining of discoloration of hands and feet after third cycle. From around this one, maybe her third cycle date was there. So they didn't give her any treatment for this patient. So what we did, because after cycle 4, she developed. Okay. But after cycle, we are giving maximum of adriamycin cyclophosphamide only for 4 cycles. So we have not given any treatment to the patient because it will resolve by itself. Because he just started developing discoloration of hands and feet. But if the patient, like oxalin and capecitabine, we know patient will develop. So we'll start it from the day one itself. We'll advise with this thing. So when we are seeing this thing, you will have to report it. No treatment was given, but the patient will recover. Okay. This is one case, one adverse effect. Another one, a 32-year-old female patient who was admitted for carcinoma of CA cervix. So I told you patient is receiving paclitaxel carboplatin. Patient received cycle 3 on 16th. Patient complains of, see, this is after cycle 3. For first cycle, 2 cycles, she was fine. So she started complaining of taste changes, constipation, body pains from 18th to 19th. Okay. And see, she started changing 2 days after chemotherapy, she started. What all she started having? Taste changes, constipation, and body pains. So what happened? Patient took cremafin syrup, okay, when she developed. And by 19th, she was having good motion. She was passing stools fine. She stopped cremafin. And body pains, we have, because I told you paclitaxel carboplatin, we usually prescribe the patients with this pain medications like Ultracet and tablet dolo. With tablet dolo, if it is not recovering, we'll tell Ultracet. And if it is also not recovering, pregabalin. So she started taking tablets. She told me it is recovering. It's better. Okay. And for taste changes, there is no treatment. The patient was prescribed with treatment. Okay. But she did not receive any treatment for body pains. She only took 1 day and she left it. Initially, she did not take, later, she took it. But she is telling, I want to avoid pain medications. And then I did not take medication, this patient. But we have already given her, irrespective of pain is there or not, please take Dolo for 3 days and then stop it. Or, take Ultracet for 5 days and stop it so that she won't get any pains. But this lady did not listen. But after that cycle, what happened? When she came next time, she told me, Madam, I need medications. The severity of body pain started increasing. And she started taking Ultracet and she felt relief from the next cycle. So this patient is very nice. Like she is a 65-year-old female. She's a vegetarian. She's a known case of locally advanced CS stomach. She was reading docetaxel flot regimen. And what happened after cycle 3? She was found to have hypokalemia. Her son started calling and telling she's having a lot of loose stool. She lost appetite. She have everything. Then what happened? They have taken to a nearby hospital and they have given her even saline infusions in previous cycle when similar complaints were there. And after cycle 3, like she literally started, she's not able to get up from bed also. She's not eating anything also. So the patient came to emergency department and patient was treated with injection KCL and MGS for over 1 hour. And also we have given her some supportive medications, okay? And counsel to prevent similar reactions after next cycle. And you know what happened? Patient had so many loose stools, like 8 episodes for 3 to 4 times in a day. And then another thing, what happened to the patient was, we thought, 5FU, what will happen? The dose of 5FU, which was given to her, was reduced to half, suspecting a DPD mutation. DPD means dihydropyrimidine dehydrogenase enzyme deficient. So that enzyme is responsible for the metabolism. So if that is not present, what will happen? That 5FP will not get excreted. Since they are like very good people, like very rich, affordable, they have done this test, and we have found the DPD mutation was not there. It was recessive, it was not dominant mutation. And then, for after next cycle, the dose have been increased to the patient. She's having severe loose stools. Not everybody we saw with this flawed regimen. Some people tolerated very well. Okay. For 5FV, there is something called as IV related side effects also, infusion related side effects also. Okay. 5FV. It is very, very, when it causes loose stools, it's horrible for a patient. She was literally from morning till evening in the hospital. But somehow she's completed all her cycles and she's fine going for surgery now. So you see this growth factors, Hafu screen. So done, guys. Any doubts? You want to ask anything? Did you get overall idea? I forgot to tell you one topic. Something called as drug interactions, right? We didn't discuss. I'll tell you. It's very interesting topic. So drug interactions are very important. See, for example, you take, 6-mercaptopurine cannot be given with milk. Okay. Why 6-MP cannot be given with milk? Anybody? Hafus creams means nothing, ma. Hafus cream is like which I was telling you. See here. One second. I told you oxaliplatin, you will have discoloration of hands and feet, right? It's a urea cream. So you will be giving it to prevent the blackish discoloration of hands and nails. Hmm? So you will be giving 6-mercaptopurine with so many drugs, okay? Means you should not be given it with milk. Why means milk will contain xanthin oxidase. This xanthin oxidase will break down this 6-mercaptopurine. So what will happen when you take 6-MP with milk? This milk will decrease the effectiveness, it will increase the metabolism of 6-mercaptopurine. That is why you will tell to take 6-mercaptopurine tablets 1 hour before or 2 hours after meals. And you have to avoid consuming this dairy production. Okay. So this is one drug-food interaction. Drug-drug interactions, like many anticoagulants will be there. If the patient is on anticoagulants, you have to check for drug interactions. Whether how it see enzyme inducers, okay. In enzyme inducers is if some chemotherapeutic drugs are undergoing metabolism via like CYP3A4 and all this. So what will happen? You have to avoid those drugs. Suppose like some example like methotrexate, it will interfere with carbamazepine. So what will happen? It will decrease the serum levels of carbamazepine and all. So you have to monitor the levels of anti-epileptic drug. And when you're giving probenecid with methotrexate, what will happen? It will increase the serum level. There is one more drug, ruxolitinib. Ruxolitinib, when you're giving with antifungals, the serum levels of ruxolitinib will increase. So you have to avoid the combination. Okay, like this, you will have to check for so many things. Because suppose if the patient is having high dose methotrexate and oriconazole is given for such kind of patient. So you have to search for another prophylaxis posaconazole or something because it links the phototoxicity for the patient. And when irinotecan is given with CYP3A4 inhibitors, what will happen? It will increase the serum level of irinotecan. So you will have to use alternative for this. And you have to see because SN38 metabolite, irinotecan toxicity will be there. And lapatinib which is used in like oral chemotherapy, it will interfere with digoxin. If the patient is on digoxin, it will increase the serum levels. So you have to check on this. So you have to check the drug-drug interactions mainly for anticoagulants, anti-epileptics and all this. drugs. Okay, and drug food interactions. Most of the oral chemotherapeutic drugs are taken in an empty stomach for better absorption and same time every day. And after depending on the this thing, depending on how much gap it is, you'll have to monitor for effects. See, we don't have much evidence or report on recurrence after CAR T cell therapy in research. We are giving and it is acting well. Okay. How many years till now is our patients like recently? Very, very few patients had CAR T cell therapy. Okay. We have to follow up the patients. Like how many years they will go, depending on the age factor also. Okay, we have very few reports are there on how CAR T cell therapy is working, and still, like research is going on, follow up is going on for CAR T patients. Now we gave CAR T for 2 CAR T have been done here, and it is good. Patients are doing good. Okay, any other doubts, guys? And I'll tell you some more example. We have gemcitabine carboplatin. We are giving for urothelial carcinoma for those patients after day 1 and they had severe constipation. Patient used to die out of constipation. They used to come and complain. So many patients on constipation. And some patients who are taking paclitaxel have been complaining about so much of neurotoxicity. So what we have the severe body pains. So what will happen is we have changed the formulation, from paclitaxel to paclitaxel. Aqualip had lesser side effects when compared to Taxol. Means normal formulation and Aqualip. Liposomal means the formulation is different. Aqualip. Micrometastatic, there is no diagnostic criteria. So that is the reason you will give adjuvant chemotherapy to kill even if 1 or 2 cells are present so that it won't recover. Means after surgery you are giving it, right? To give any other cells, you will have like small 4 cycles you will give and you close it. Sometimes we'll give neoadjuvant and adjuvant also. And sometimes post surgery you will give radiation because depending on type of cancer. Any other doubts? Drug food interaction. See, for example, drug food interactions means what will happen is suppose like xanthine oxidase inhibitor, right? 6 MP. And this milk will contain xanthine oxidase. What will happen? It will go and break down the 6 MP. So what will happen? The drug will get metabolized fast. So you will have less efficacy of 6-mercaptopurine. That is the reason you will not mix milk and 6 MP. Lenalidomide will be given with dexamethasone. You have so many criteria for oral chemotherapeutic drugs. If you go on, you have lot many. And 1.5 hours is not sufficient. Okay, guys, would you like to have more and more new classes? Because every topic I have to take in detail means you need so many case discussions. So if you people have LinkedIn accounts, please go and post your learnings from the class in the LinkedIn, okay? Whatever you have learned, I'll feel happy like you have learned something from my class. Any other doubts, guys? If no doubts, shall I switch off? Why CAR T cell therapy is so costly? Process of infusion. Process of infusion is simple, but the introducing a CARs, that receptor onto your T cells and cultivating and culturing lots of millions of cells is a very big process, and the reagents are very expensive. The transport storage of all that is around minus 196 degrees centigrade. You have to thaw CAR T cells and then immediately infuse them. Okay. Anything else? It's like I'm giving an SDP, but mm, the process of preparing it is very expensive. The reagents are very expensive. And once the CAR T is made, if it is not infused, it cannot be given to any other patient. Can I tell good night to everyone? Did you have a good learning in the class, guys? Sorry. Okay, guys. See you. If anything, you can post in the group. Can I log out host?
Yes, ma'am. Thank you for this wonderful session. I think our students learned a lot today.
Thank you.
And before leaving, guys, please remember to fill in the feedback form that has already been shared.